In fact, using the same slide, this is my third or fourth presentation. So some of you may be familiar with my presentation. The bottom line of my presentation is it looks like those 216 cancer patients seems to be real cancer patients. That's what I wanted to say. Well, anyway, before I proceed to my presentation, in the morning, Dr. Sue Lee made a very, very important point at the end of her presentation. It's about the next year observational studies ongoing right now in the medical center. That is, you talk about the effect of next year. In fact, that is not really effect of next year, but in the presence of concomitant therapies. So unless you have a very good record of what concomitant therapies are given, like massage, herbal treatment, acupuncture, and what have you, the value of your study can be compromised. And therefore, I propose you to make a very good record of those concomitant therapies. And, modern statistical technology can account for the effect of those concomitant therapies. But make sure it has to be very well, clearly, and recorded in very organized manner. And also, Dr. Kim's presentation in the morning, the goal of study was not clearly stated. Is it the prognostic factor study, or is it a treatment study? And I think that the goal of study, any data analysis, any study, should be very clearly delineated. Otherwise, people will have a pot shot at your presentation. One other thing, I think Dr. Hoshino said that the Western medicine is a medicine of science, and the Eastern medicine is medicine of indication. I think that's very correct. One medical doctor who passed away last year, Professor Dr. Park Sung-yeon, he was a Western medicinist, and he studied the diabetes throughout his life. His conclusion, was very interesting. He says, Western medicine doesn't have a philosophy, and the Eastern medicine lacks scientific approach. That's exactly what Dr. Hoshino said in different ways. And I think that the effort in this setting has to be that the weakness of each other should be compensated, and the strengths of each other should be combined together, rather than promoting my method is better, my medicine is better. And that's what I want to talk about. Clinical trials in Eastern medicine, the clinical trial of Eastern medicine should be evaluation of Eastern medicine by Western criteria. I think that's the first step toward the integration of two medicines. In fact, that I've been talking about the integration of two medicines since 1999, and I've been preaching that. And I think that this presentation, in fact, is a result of my belief in how we can combine two medicines together. Because I have already lost 5 minutes, I will try to be very brief. As everybody knows what is next year, so I'll skip that. And this is about the Korean version of what is next year about. Now I think that the goal of study, that when Dr. Won-Chul Choi bragged to me about his patient's survival, I wanted to say that is it true? I think that's the first question I had. Are you sure that they are really cancer patients? Cancer patients are not supposed to live that long, especially terminal cancer patients. And that was my first question, and that was the question that I've been pursuing in this presentation. 250 sort of quote-unquote cancer patients treated at Dr. Choi's clinic. 34 had to be excluded because in 5, no diagnostic data. 6, misplaced charts, record missing. 21 patient didn't get enough treatment. 1, I forgot what it was. So 34 patients were excluded. There are 216 patients left. I think that with whatever we can put on our hand, we have, and those data stored in Gwangheon in Incheon. And this is a blood cancer. And this is stage 4. And this is some patients get the chemo and Nexia together. Others just get the Nexia alone. And some patients didn't know whether they were getting combined or by itself. So they show different survival, somewhat different survival experience. And I think one very important finding here is somewhat dose dependent. Namely, the higher the dose of Nexia, the survival experience seemed to be better. And in fact, that's significant. P-value is 0.0001 by log length test. So why do patients with primary care hospital data survive longer? Well, they lived long enough to go to the hospital to claim their chart. I mean, that was very simple. It didn't occur to me until I was preparing this. They lived. They've been living. So they went there. They listened to Dr. Choi. Dr. Choi told them, please go and get the medical chart. And they went and get the medical chart. So the survivors did that, and therefore the patient with primary care hospital data survive longer. Well, the patient with primary care hospital data survived better than patient without it. This implies that probably all these 216 patients may be really cancer patients. I mean, that seems to be the answer. So after all, Dr. Choi didn't lie to me. When he said they are all cancer patients, they may be genuine cancer patients. I think that the most important point of this presentation is those 216 cancer patients may be, or very likely to be genuine cancer patients.